Thanks very much. I'm really very honored to be asked to speak here. One of the pleasures in my life has been that my professional career intersected with my parents, and going to medical school in Colorado and then going to residency in Rochester, I just cannot begin to count the number of times, but it's got to be in the hundreds, where I introduce myself to somebody and they say, "Are you Farley? Are you related to Gene and Linda Farley?" And I really like that a lot. And my oldest daughter now works for the National Council for Behavioral Community Health Centers in D.C. And I also have the fortune to be able to interact with her professionally. And I was at a meeting about a year ago, and I introduced myself, and somebody said, Farley, are you related to? And I said, yes, Becca Farley in Washington, D.C., that's right. But I do have one story I want to tell about my folks, which Val touched on when they would go across the country reading to each other. For those of you who know my dad, fresh air is good, right? The more fresh air, the better. So when we were growing up in that house, the last thing he would do, he'd come in and kiss us goodnight and open our windows. And it didn't matter. We grew up this is in upstate New York, and it didn't matter if it was 20 below zero out. The window's going to be open. And sometimes we'd wake up, with the water next to the bed frozen. But for him, fresh air was the most important. For those of you who've been to his house, it's as close as you can get to being outside without being outside. So when we went on these family vacations, we would always drive with the windows all the way down in the van. So we'd be like 4 kids in the back fighting and mom and dad up front, all the windows open, driving down the highway. You can imagine the chaos. And my mom reading. And so then she'd have to yell at the top of her lungs to get over that wind noise. And some of the books they read were, we'd always laugh about, the latest book they were reading, global corporations out to steal the world. And anyway, so what I'm going to talk about, it says in the program I'm going to talk about the Colorado Health Equity Program. I'm going to mention that, but really I'm going to I've expanded that talk to really address ways in which at least my health center, and I think the way my health center does, and I think all health centers can, start to step outside clinic walls and incorporate some of the social determinants of health into our scope of practice, because really that's where health is determined. So Salud Family Health Centers, we're a full-spectrum migrant community health center serving a big chunk of northeastern Colorado. This is a map of Colorado, and if you think of Denver as kind of the section of the intersection of the 4 quadrants, we sort of cover the northeast quadrant from the northeast border of Denver to Wyoming, and then from the Continental Divide across to Nebraska and Kansas. So it's a pretty big area. We have 9 sites plus a mobile unit. Our clinics are rural to urban. We take care of about 80,000 unduplicated patients, making about 300,000 visits. The vast majority of our patients are really poor, and about almost 2/3 are Latino. So we have pretty fully integrated services, and when I say integrated, I mean fully integrated. So when I go see patients in our Fort Lupton clinic, I'm seeing the same patients at the same time as a mental health person and as a dental hygienist. So, I'll go into room 1, maybe while the mental health person is in room 2. I don't have to ask her to go see anybody. She just goes in and sees folks, and then we confer on the way out, and we switch. That if there's any kids in the room, the dental hygienist goes in and puts fluoride varnish on everybody. We have patient health educators also in that system that's automatically see anybody with chronic disease. We have care management that take on the highest risk patients, and then we have a pretty robust transitions of care team to move people from hospital to home and back to clinic. So it's pretty fully integrated services, but there's still a ton of disparities in our communities. Our communities are low income because we're a low income health center. There's not good housing. The schools are all way underperforming, which means lack of opportunities for area high school grads. I can't remember the exact number, but something like 80% of the high school grads in our communities are not felt to be ready for college work, that they need remedial education before they can go to college. And then a very high Hispanicity, so a lot of recent immigrants with all the, including a lot of undocumented immigrants with all the marginalization and health problems that come from that. So, as everybody knows, 90% of health outcomes are related to the social determinants of health, and 10% are related to what we do in our clinics. So, I've been hearing about this from my dad since I can remember, because he started on the Navajo reservation on a community tuberculosis project, and that's where he really first developed age-sex registries and neighborhood mapping of patients and all that sort of thing. So, I've been hearing about this stuff forever, but it does make a ton of sense that really to make the best or the biggest impact on community health, we have to get outside of the clinic walls. And, everybody knows what the social determinants are. So this is really the premise of my talk, and really the premise of my professional career right now, which is that we can and we should address the social determinants of health in primary care clinics. And it's the only way we're really going to make a big impact on population health in low-income communities. High-income communities, they're on their own. They're going to have to suffer through on their own. So I'm going to talk about three areas in which Salud has gone pretty markedly, I think, outside of what's considered general sort of primary care. The first is environmental health. So a lot of our patients, we take care of a lot of farm workers, and a lot of our farm workers live in housing kind of like this, with maybe an irrigation ditch going through the area, a lot of freestanding water. There's a bucket there with water in it. So there's a lot of mosquitoes. West Nile virus is a big deal for us. We're generally one of the top couple of states in West Nile virus. So we do mosquito trapping. So we start to trap mosquitoes, sometime in the summer, and we measure the mosquitoes that carry West Nile virus, and when they get to a certain percentage of the total mosquito population, then we start to worry about whether West Nile will be a problem clinically for us. But then we also, this is a little fish called the Gambusia fish that eats mosquito larvae, and we'll get this fish from the state and go dump it in the irrigation ditches and the open ponds and all the things that are in our communities. We don't want to put pesticide in the water for all the obvious reasons. So the Gambusia fish is a good alternative. Every red dot is a fracking well. And that's kind of the center of our catchment area there in Weld County. It's the number one highest number of fracking wells of any county in the United States. So, people are worried whether fracking chemicals get into the groundwater. So our patients can request that we go to their house and test their well water for fracking chemicals. We're also engaged in workplace safety, and again, particularly with farm workers. This is an onion field near where I work, and so these guys are picking onions, and there's spraying done right next door. We try to work really collaboratively with the growers. We don't want to demonize the growers in any way, because we don't want to make them our enemy. We want them to remain our friends, so that we have a little more influence with them. So we talk to them about pesticide safety, try to figure out when they can spray the field safely when the workers aren't there, and then we also make sure they follow the rules on how much water the farm workers have, and whether they have toilets and all that sort of thing. NIOSH gives us a bunch of bike helmets, so we give bike helmets out to every kid. And we used to give car seats out to every family, but that grant ran out. But the point is that most of those services are things that I think Kaiser would not probably be engaged in. but it's what our population needs. Access to legal services. This is a strong statement, but I believe it's true. All people living in poverty have legal problems. Being poor is just is the result of and often sets you up for lots of legal issues. And medical legal partnerships can improve the health of low-income populations. Doctors and lawyers working together can really do things that doctors alone have no ability to affect at all. So we did a legal needs assessment in one of our clinics. In 2 weeks, we interviewed 600 people, and we found that 2/3 of them had had a legal issue in the past year, and almost half of those 2/3, so almost a third of the patients, had an ongoing legal issue that they felt was negatively impacting their health. And essentially none of them had access to legal help. Really the only time you have access to legal help if you're poor is if you're trying to get disability, because the way disability works, the lawyers get paid by the government if they win your case. So we started a partnership with the CU Law School and one of the biggest and most prominent law firms in downtown Denver. I mean, they have a 50-story skyscraper on 17th Street in downtown Denver called Holland and Hart. And our goals are to provide service, so to give pro bono legal services to anyone who needs it. Provide education. If you're a law student at the University of Colorado, you can take a class called Poverty and Health Law, and that class happens at our Commerce City clinic. And then finally, to change policy. You know, we want to collect data and have influence on the state legislature so we can make policy change as necessary. The main areas that our lawyers look at are these. They call it I-HELP, income supports and insurance, housing and utilities, education and employment, legal status, and personal and family stability. And just to put this into perspective, there was an article in the New York Times within the last week on just the scope of employers screwing their employees out of wages and benefits. So that's one of the things we're really going after. And then I don't know what it's like in Wisconsin. In Colorado, the anti-immigrant character of the state is pretty significant. So it's tough to be undocumented. It's tough to be an immigrant of any kind in Colorado, and particularly if you're undocumented. So they do a lot of work on folks that are in a bad position because of their legal status. So we just started. We're only in our second year of this right now. The first year we took care of 10 patients is all, but we had great success with all 10. And it was when everything from, you know, the refractory asthmatic patient who can't get better because they live in a mold-filled apartment, you know, so we fixed that, to the person that got evicted illegally by their landlord, to the the dream actor, the dreamer, whatever we call them, who needed ablation of her thyroid but was having trouble negotiating that system. So it's really been a tremendously successful program for those 10 folks. We're expanding it in year 2 to, depending on whether our grants come through, to maybe up to 100 people. But the lawyers, their goal for this thing is to make it so that, I don't know, 3 or 4 years from now, any Salud patient with a legal problem can get pro bono services through this program. And then the last program I'm going to talk about is education. So education is a big deal. And if you're in a low-income community and going to low-income schools, you're going to have a tough time getting education past high school. And education is a huge predictor of health outcomes. In fact, there was a study done out of Virginia Commonwealth University 5 or 6 years ago that looked at the amount of lives that could be saved by correcting the health disparity in education, by correcting the health disparity in race, as compared to the total number of lives saved by advances in medical technology. So they estimated the total number of lives saved by advances in medical technology during the 90s, figured out how many would have been saved if we could correct the disparity in mortality in people with no college education versus people with some college education. and that's a factor of 8. So you'd save 8 times more lives if you could correct the education disparity than were saved by advances in medical technology. So if you look at education over the years, we've done a lot better with high school education. If you compare 1970 to 2010, African Americans are graduating from high school at a rate close to that of whites, although that doesn't tell you very much, right? Because if you graduate from, a kind of a crummy school in the middle of Milwaukee, that's a different education than if you graduate from a charter school out in the suburbs. Mexican Americans lag behind pretty substantially. But if you look at college graduation rates, then things really get bad. So, there's a huge disparity there. So at Salud, we've done a couple of things. Most of the people that we hire have a GED or maybe a college, or maybe a high school education, and we train them to be, nursing or medical assistants and front desk staff and all that. We've been doing that for many years, but over the last couple years, we've put in a sizable investment into improving that education so that they have more opportunities. So, for example, we have about, in our system, we have about 150, I think, medical assistants, and I think 4 of them were registered medical assistants. So our commitment to our employees now is that by January 1st, 100% of those medical assistants will be registered medical assistants. And all of that's coming out of our, we're funding all that. We're funding teachers for them and online coursework and paying for their exam and everything else. And, that'll make them much more employable outside of our system. But we really believe that then our job will be to create a job that can compete with Kaiser for the best trained MAs, and because that's what we think they will be. And we've even taken this to the level of building an administration of what we call the Administration and Training Center, which is a pretty good-sized facility. It houses a lot of our administration, but the whole second floor is a training area, and we have these training bays or whatever you want to call them that are set up with all the diagnostic equipment that we have, the way we have them set up exactly in all of our exam rooms. So when we train students in this facility, when they go out to the clinic, they'll see it exactly as they saw it in the training area, and then also all the same lab equipment. So once they leave our training facility, they go out to the site, and it's exactly the same. HemaQ, microscopes, centrifuges, everything's all exactly the same. And then last year, we decided to take it a step farther, and actually, we spun off a 501c3 called the Salud Institute for Community Health Careers. It's a school recognized by the state. It's a professional occupational school. So we're eligible for grants from workforce training centers. And ultimately, we will be able to, students that come to this school will be able to get HEAL loans and health professional loans to pay for their education. And we think we can provide that education at a higher quality and probably a sixth of the cost of what the private for-profit schools charge. So we think that at least in our catchment area, we will be able to make a significant dent in the number of kids that end up going to these, profit-making schools that don't give them a good education and leave them with a huge debt. And then ultimately, what we want to do is, be the premier training facility for a wide variety of entry-level staff in community health centers, at least in Colorado. So, I think that, all these ideas about working in community definitely came from my parents, but they're good ideas, and we should all be doing it. So that's my talk. Any questions about anything or comments or experiences in your own place? You know, one thing I found is if you have a good idea, someone else has that idea too. And you got to figure out who that person is and get with them. So, for example, the Colorado Health Equity Project, I was at a meeting with some medical students in Long Beach a few years ago. And one of the students had wanted to start a free clinic. I'm not big on free clinics. You know, I think that everybody deserves the highest caliber health care you can get. And we shouldn't relegate big chunks of our society getting their care by volunteer students and doctors at, you know, part-time clinics. So anyway, I didn't tell her that, but her project didn't work out. So she said, I have another idea. I think we should do a legal needs assessment in your clinic. I said, hey man, that is a great idea. And so she did that study. And then she went to the law firm. Law firms, they like to do pro bono work. And the big law firms, instead of having each lawyer do some pro bono work, a lot of times they'll have a pro bono department where all they do is pro bono work. So, you know, the law firm is trying to figure out how to do pro bono work, and we need pro bono work. All we had to do is get hooked up. So these lawyers, I tell you, they are totally gung-ho on this thing. This is their mission in life, is to make this thing go. So we've applied for a couple of grants, but they have a lot of volunteer lawyers, and we're gonna fund it. If we can get, we have a grant right now for I think $50,000 in front of the Colorado Health Foundation, which is the biggest charity funder for health in Colorado. If we get that, they're convinced we can get services to every one of our patients with needs. Let's see, the environmental health thing, our director of environmental health, he cobbles together all sorts of grants from all over the place, NIOSH and the NIH and all sorts of different groups. And these projects I'm talking about, they're not always operating all the time. We're running our mosquito trapping program right now with a fellow, an epidemiology fellow. The bike helmets is a grant from NIOSH, so we have, I don't know, probably 1,000 bike helmets around. But funding always is a problem. I think the thing to avoid is a funding mechanism that relies on some sort of widget, a face-to-face encounter with a license. I think that's rearranging deck chairs on the Titanic, and we should not go there. I think the key is to figure out who else has that great idea and work with them. And there's a lot of ideas that, you know, that is a damn good idea. We're going to do that thing as soon as we figure out how to fund it. So you just kind of keep it simmering there on the stove, and eventually it gets to the front burner. I think, again, what I learned from my dad is, you know, there's no bad ideas. And so I think I have the reputation in Colorado, if someone has a crazy idea, they can come to me and ask, hey, what do you think about this? And, you know, there's a ton of great ideas out there. And so then the question, though, becomes, once you start a program, how do you keep it going? Why does it not just fade away? And then you do need champions to run it. So we have a very dedicated director of environmental health, and I have to go to him frequently and say, Ed, tell me what you're doing now, because I need to go give a talk. Tell me the latest thing that you're doing. Because I think the other part of it is, you know, you really don't want to squelch ideas and innovation. So he knows that, you know, sometimes he feels like he should send me an email or something and say, hey, I'm going to do this thing now. But I don't think I've ever told him no, because they're screwy ideas, but I really like them a lot. They're really great ideas. And if you get a champion who's really invested in it and you don't step on them, then I think most programs will keep going. And some of it is changing the way people think. Like the school took some serious sort of convincing of my CEO that number one, it's okay to charge tuition to people, even if it's 1/6 of the tuition of the private guys. And number two, that even we should be in this business, because it's not healthcare, but it is totally healthcare. To implement this thing, we hired a full-time educator. So the person that's running it is not a medical person at all. She's an educator, and she has taken some of her training staff. Now consists of some of our MAs, people who used to be our MAs. So she has developed that in her workforce. How that continues in the years to come, I don't know, because they're all like, 30. So they might be around for a while. But if it can't propagate itself, then it's not sustainable, and so we have to solve that problem. Yeah, so part of the reason we started this training thing many years ago is because we found it was way easier to find someone that spoke Spanish in our communities. It was way easier to find a bilingual person and teach them to be an MA than it was to find a registered MA and try to teach them Spanish. Because in our communities, everybody speaks Spanish. Everybody's bilingual. So yeah, our staff, one of the requirements of the job is you have to be bilingual. We make the exception with some providers, so probably 2/3 of our providers are bilingual. But then you get into questions of what is bilingual, what does it mean to be fluent? What does it mean to speak another language? Because, I've been speaking Spanish for 25 years and I would not consider myself fluent. I rarely need anybody I never need an interpreter. Sometimes I need somebody to tell me what one word means. But even still, I know that I miss a lot of nuance. And so if you're really going to have translators and be fully bilingual, then you have to start testing people on their language ability. And we're not there yet. But all of our support staff is what would it be called? Natively bilingual? Something like that. Yeah, so Colorado was an early adopter of the ACO model. So we have 80,000 patients, and already, just since January 1, about almost 30,000 of them are in an ACO. So we get a per member per month for each one of those 30,000. And it's not based on widgets. I just love the ACO. I think it is. Who was I talking to John about it? Yeah. You could call it chaos, but you could also call it disruptive, sort of transformative opportunities. And so all of a sudden, we're getting a couple $1 million a year that's not attached to me seeing a patient. So we can innovate with that however we want. And so I think, is Wisconsin at that level yet or no? No? Well, once they get there, I just would really strongly encourage you to, not to use a cliche, but to use a cliche, go where the money is. And the money isn't, buying a new machine for the clinic. The money is in something else. We have a really cool transitions of care program where every patient in our doctors don't do a lot of medicine in the hospital anymore. But every Salud patient gets rounded on in the hospital by a non-medical staff person who rounds on the patient with the discharge planning team, gets to know the patient, gets to know the discharge plan, stratifies for risk of readmission, and then does home visits within 48 hours of discharge. And they do all sorts of stuff from environmental safety assessments to med reconciliations in the home. So they come up with a list of what this patient needs, and it could be anything. It could be, they need a rail for their bathroom to, they need a better way to ensure they get their meds refilled on time. So I think the answer to that is think about using that money outside the clinic walls, not inside the clinic walls. Yeah, I make house calls. We have a variety of non-medical people that make house calls. Our care managers do. Our transitions of care team does. Our clinical pharmacists do. Sadly, I think I might be the only doctor in the system that does. I guess all these years later, we're still looking for the family and family medicine. And the best place to find the family and family medicine is in the house. That's the place to go to find the family. And I think not enough young doctors are thinking about it that way. Not that we're not young doctors. We are. All of you all are in advocacy roles. Everybody in family medicine, everybody in this room I know is an advocate. And you cannot be an advocate without pissing people off. So I think the way to do it is nicely, nicely. we actually are very good friends with the growers in our area, and if you read, around the country, most migrant health centers are not on good terms with the growers. The growers like the enemy, but we've really nurtured a good relationship with the growers because if we do our job well, they make more money, and I used that as a ploy to get money out of them, and it didn't work. But I think that's true for a lot of things. Now, the tenant that doesn't, or the landlord that doesn't want to clean up that mold in that apartment, that's just the law. You just got to obey the law. You have to do what the law says you have to do. And if I make that guy mad, I don't care. If I make our growers mad, I don't like that because I can't work with our shared population if they're mad at me. But I guess be nice when you can, and don't be nice when you can't. So we take our Salud Family Health Centers is the largest off-site trainer of students for the University of Colorado School of Medicine. We also have a lot of residents rotating through, and then we're working with the Department of Family Medicine right now to start a residency program in our Fort Morgan office, a rural residency, which would be what do they call them when the first year is in 1+2 with 2 residents each year. So we're developing that. The business model for that doesn't look good. So historically, there's been a big tension between service and education in health centers. I mean, either you serve or you educate. You can't do both. And we've never bought into that at all. We expect when we hire people, we tell them you're going to have to teach. Everybody in our staff is clinical faculty in the Department of Family Medicine. But I also tell the school that they cannot ask us to do things that's going to negatively impact our bottom line. And sometimes I think academic centers, because of the rules the Residency Rules Committee puts on you all, I shouldn't. I'm just going to leave it with Colorado. Colorado's a great Department of Family Medicine. They have Larry Green and lots of other really good thinkers, really good people. Sometimes I think they fall behind what's actually happening out in the real world. Like hospitalists are not a fad. Hospitalists are here to stay. And there's good things about hospitalists. And to me, the fact that hospitals are now using hospitalists gives us an opportunity to do something even cooler than, going in and seeing the guy with pancreatitis and making sure his lipase is okay. Now we can put in teams that will go to their home, get to know them in the hospital, and then go to their home. So sometimes I get pushback from the department on, our residents aren't getting the right thing here. Well, this is how we're doing it. This is how things are moving. So they have to adjust to that. We can't adjust to them. But I think the education service conflict is false. I don't think it needs to be there at all. All right, thank you very much.